This is FX Radio and I'm Andrew Whitfield Cook. And with me on the line from Boston University today is none other than Professor Michael Holick. Now, Professor Michael Holick is well known and really doesn't need an introduction, but he's the Professor of Medicine, Physiology and Biophysics at Boston University School of Medicine. He's Director of the Vitamin D Skin and Bone Research Centre, Laboratory Program Director, General Clinic Research Unit, Director, Biologic Effects of Light Research Centre and Director of the Bone Healthcare Clinic all at Boston University. Welcome, Michael. Welcome back.
Oh, it's always a pleasure, Andrew.
It's been a little while since we've spoken and there's a lot happening out there in the world with vitamin D research. So tell me the latest. What's happening with good research, bad research, maybe some controversies?
Sure. So I think the first controversy really came out in Lancet when it was suggested by Audier that, hey guys, the story about vitamin D deficiency needs to be turned around, and that all of these chronic illnesses that we've been talking about, increasing risk for vitamin D deficiency, is the other way around, that it's the chronic disease and the inflammation that's causing the deficiency, not the deficiency causing the chronic disease.
Right.
And in his article, he quoted two publications, one actually from an Australian group, John Eisman's group, suggesting that they had published two studies to show that in an acute hospital setting, that when there was inflammation in the patient, that the vitamin D status, the 25-hydroxyvitamin D levels, declined. So that proved the point. So I happen to know those two publications well, and so I wrote back with Bill Grant to Lancet explaining to them that indeed they either misread or misinterpreted those papers, and neither of those papers suggested that chronic inflammation causes vitamin D deficiency. But rather they were saying that vitamin D deficiency was incredibly common in these patients who were coming acutely to the intensive care unit for a whole variety of different reasons. And so even though there is this paper out there and some people have kind of embraced it, in my opinion, there's just no evidence to suggest that it's the chronic disease that's causing the deficiency, but rather most of these association studies are suggesting that it is the vitamin D deficiency increasing risk for chronic disease.
Right.
The second controversy that's out there is that there's this concept that, a little is good, but too much is probably not good. And even though that's true, whether you're drinking water or no matter, or whatever it is that you're ingesting, is that the vitamin D story is a little bit different. It was suggested initially by the Institute of Medicine and then followed by several publications to say that, yes, we all agree, if you're vitamin D deficient and you improve that deficiency, you definitely reduce mortality. So you improve overall health and welfare. But that if you get much above 75 nanomoles per liter, you all of a sudden have this called U-curve or J-curve, where all of a sudden now the mortality rate is actually going up. So now they're suggesting that you have to be incredibly cautious about how much vitamin D you're taking because you have to have this kind of magical level of around 50 to 75 nanomoles per liter, and much above that increases risk for mortality. So recently, Dr. Garland has looked at all the publications and has now concluded that indeed when you look at risk for mortality, and it's mainly cardiovascular mortality, that the incidence continues to decrease, and even up to 150 to 200 nanomoles per liter, you still get that benefit.
So when you're looking at healthy or optimal levels of vitamin D, I remember you looked at vitamin D levels in African natives, and you found very high levels, didn't you?
Yeah, so it wasn't me, but it was a publication that had reported in both Maasai warriors and another group of Africans that live outside all the time, that their levels were around 150 nanomoles per liter. So we think that evolutionarily that's where we all should be.
Right.
And we've just completed a study. We haven't published it yet, but in African children who are outside all the time, we find exactly the same thing. That their blood levels are somewhere in the range of 100 to 150 nanomoles per liter.
And yet there was a study looking at Hawaiian surfers some years ago, and they found, curiously, extremely low levels of vitamin D. Do you know about that one?
I certainly do, and it turns out that that's a misconception out there, because that's what you, of course, see on the Internet. If you read the paper carefully, it turns out that they weren't surfers, but they were skateboarders. Number one. And number two is that they never told you that this was in the wintertime. And so they assumed, because you're in Hawaii, which is at about 34 degrees latitude, that you're making vitamin D all year round and all times of the day. Skateboarders are out there in the morning and late afternoon.
Yeah.
And the study was done at the end of the winter.
Right.
So we know that living above about 34 degrees latitude, you basically can't make any vitamin D in your skin in the wintertime. And you don't make very much of any vitamin D even in the summertime at 8 o'clock in the morning or 4 o'clock in the afternoon. So in my opinion, there were really major issues in terms of interpretation for that study.
Absolutely. Is there any good research that looks at pale-skinned humans or white-skinned humans at higher latitudes where they've evolved to live?
Well, they've looked at, of course, lifeguards. And lifeguards will have, on average, in the range of 150 to 200 nanomoles per liter. We did a study in tanners in Boston in the wintertime, and again, we found them to be at around 115 nanomoles per liter. And when we looked at their bone density, it was actually higher than adults matched for both sex and age who were non-tanners and were vitamin D deficient in the wintertime.
And this is sun exposure, so this is natural absorption and manufacture of vitamin D through its normal mechanism.
So the studies that we did were tanners were using a tanning bed, because in the wintertime, obviously, you can't make any vitamin D in Boston. And so we were asking the question, tanners who used a tanning salon once a week, they had robust levels of 25-hydroxy-D, like I said, about 150 nanomoles per liter, compared to about 37.5 to no more than about 45 nanomoles per liter for sex and age-matched controls that weren't using a tanning bed. And we looked at their bone density was higher as well, the tanners. And this is consistent with the National Health Survey data that Bischoff-Ferrari had published many years ago, showing that the higher your 25-hydroxy vitamin D, no matter what your ethnicity, higher was your bone mineral density.
Right. But the use of tanning beds is very controversial with the risk of skin cancer. Can you go through that? Because there's some differences in the types of tanning beds, isn't there?
Sure. And so most of the tanning beds are putting out UVB. They're mimicking sunlight. And what I typically recommend for anybody that wants to use a tanning bed for their vitamin D in the wintertime is to go in for about 50% of the time recommended for tanning, maybe no more than twice a week, and always protect your face because it's the most sun exposed and most sun damaged. And since your body can make up to 20,000 units by getting what we call a minimal erythemal dose, they're probably getting on average about 8,000 to 10,000 units of vitamin D just by doing that. And that satisfies their requirement. They do it twice a week for the entire week.
I always love talking to you to tease out the realities of the research. Michael, thank you for going through that. And now on to our topic of the month, which is vitamin D in pregnancy, its uses, its cautions, and there's some myths around it. So I think with the first question, can you just recap about the effects of vitamin D from what we thought was reality 60 years ago to now with, we used to think that vitamin D receptors were only in the bone, and now we know that they're everywhere.
Sure. So originally it was thought that pregnant women may be more sensitive to vitamin D, and the Institute of Medicine, when they made their recommendations for vitamin D for 600 units for all adults, that included pregnant women. We had done a study in Boston in 40 mothers and followed them during their pregnancy, and they were taking their prenatal vitamin, just like an obstetrician would recommend, and that contains 400 units of vitamin D, along with drinking 2 glasses of milk, which contain an additional 200 units. So they were getting 600 units of vitamin D a day during their pregnancy. Yeah. And they admitted that they were taking these at least 70% of the time. At the time they gave birth, almost 80% of the infants were vitamin D deficient. 76% of moms were vitamin D deficient, less than 50 nanomoles per liter.
My gosh.
And why should you care? Because we and others have shown that preeclampsia is associated with vitamin D deficiency during pregnancy. Vitamin D is very important for proximal muscle strength, and we went on to show that in over 200 women at our hospital, if they were vitamin D deficient, had probably a 4-fold higher risk of requiring a C-section during a pregnancy. There are other studies that have shown that poor birth outcomes, low birth weight, may in fact be associated with vitamin D deficiency. A very nice study was done in South Carolina by Bruce Hollis and Carol Wagner. And what they did was to give pregnant women throughout their pregnancy either 400, 2,000, or 4,000 units of vitamin D a day, followed their vitamin D status, their serum calcium, and 24-hour urine calcium, which is the most sensitive indicator if there's any perturbation in your calcium metabolism. And they found that women on 4,000 units of vitamin D a day during their pregnancy maintained a blood level in the range of about 125 nanomoles per liter. There was no change in their serum calcium, no change in their urinary calcium. There was no untoward toxicity. And there was a suggestion that there was better outcomes for the pregnancy as a result of that increased vitamin D intake.
And indeed, Dr. Jenny Gunton and her group did a trial at Westmead Hospital in I think it was diabetic women, pregnant women, and they found an extraordinary, I think it was 40% were deficient in vitamin D in Sydney, and they used a supplement of 5,000 IU, so that's sort of 1,000 up from the Hollis group, Bruce Hollis's research on pregnancy, which was 4,000 IU. So do you say that 4,000 IU per day is recommended, or only in risk groups?
Yeah, it's a good question. And so I think that, people are always worried about birth defects and about any potential toxicity, during the pregnancy. So what I recommend is just what the Endocrine Society recommends, 1,500 to 2,000 units on top of their prenatal vitamin and on top of other sources, including some sun exposure. So they're probably getting total about 3,000 to 4,000 units a day.
Gotcha.
I don't think it's necessary for them to be on 4,000 units a day just as a supplement, but rather the combination, 3,000 to 4,000 units a day is probably just fine.
So make sure they're getting some sun exposure at midday. About 5 minutes, 10 minutes.
Correct. To use our app, the what's called the dminder.info, DMINDER.info, and you can use it in Australia. It's for both the iPhone and for the Android, and it will tell you how much vitamin D you're making based on your skin type and where you are in Australia, and it also warns you to get out of the sun so that you don't have significant damage to your skin or increased risk for skin cancer.
And it also tells you that, you've got a vitamin D opportunity coming up as well. So what about, a big issue with vitamin D in Australia has been the rise, I think it's been a 9-fold or 10-fold rise in 11 years of the vitamin D testing in Australia, costing millions of dollars of the healthcare purse. Indeed, just recently, I think it was 2 weeks ago now, it was taken off Medicare except in certain stringent circumstances. So can you go through the relevance of testing? When would you test and when would you not bother? Because you were actually called out to Australia.
Yeah, we have the same issue here in the United States. It's the most ordered assay by doctors now in the United States. And so the Institute of Medicine and the Endocrine Society do not recommend broad screening. But the Endocrine Society very carefully documented risk factors that you probably need to get a blood level drawn, and you need to be able to follow them. And give you some examples. So if you're obese, i.e. a BMI of greater than 30, you need 2 to 3 times more vitamin D to satisfy that requirement. And sometimes you can't really easily tell. So it's very reasonable for people who are overweight with a BMI of greater than 30 that they have their blood tested, given a dose of vitamin D. And I think you should be at least 2 to 3 times more than what we typically recommend, so probably about 4,000 to 6,000 units a day. And then 8 to 12 weeks later, get a blood level. And if it turns out to now be adequate, and I'd like it to be at around 75 nanomoles per liter and above, and the preference is 100 to about 150, is the 200 is ideal, then you don't need to test them anymore because you know that it works. Right? Patients on glucocorticoids, anti-seizure medications, AIDS medications, all of those medications increase the destruction of 25-hydroxyvitamin D. So it is recommended that they be tested. But again, once you have them on a stable dose and you know what that blood level is, you don't need to test them again. Another good example is patients with granulomatous disorders. They are exquisitely sensitive to vitamin D and can increase risk for hypercalcemia. So they definitely have to be followed. And again, it's the same thing. What we like to do is get them tested, and then give them vitamin D. And we usually give them about 1/2 to 1/3 the amount of vitamin D that we would recommend for a normal person. And you only get their blood level between about 50 to 75 nanomoles per liter. And by doing so, you usually will not see hypercalcemia, but you need to follow them.
Yeah.
So that's just a few examples, but we don't recommend broad screening. What we recommend, at least what I recommend, and the Endocrine Society does as well, is that people should be supplementing because the major source is sunlight. We're avoiding the sun, putting sun protection on, and there's essentially no vitamin D that is adequate in your food, so take a supplement. And that's basically what I do. I take 3,000 unit vitamin D supplement daily, drink 3 glasses of milk, get some other sources of vitamin D, so getting about 4,000 units a day. Blood level on average, about 150 to 200 nanomoles per liter.
So what about safe practice implications for dosing in pregnancy and early childhood? I know you said about 2,000 to 3,000 IU per day in pregnancy. What ramifications does that have for outcomes like preeclampsia and gestational diabetes? Yeah,
it's a good question. I mean, we don't know. I mean, studies are underway right now to look at this more carefully, but there have never been really good prospective randomized controlled trials to look at this during pregnancy. And in some ways, it's really kind of difficult to do that because you have to give them at least 600 units of vitamin D a day because it's almost medical malpractice. And no large studies have been done in a randomized fashion to look at this. But what we do know is that, again, association studies, mainly from the National Health Survey data in the United States, that children born of moms who were vitamin D deficient are more likely to have wheezing disorders in early childhood and asthma. There's a recent study even that said that children born of vitamin D deficient moms in the first couple of years of life are at extremely high risk for dental caries. And the CDC even recognizes that the most common disease in young children is dental caries above and beyond asthma or anything else.
Wow.
There was also a study done in Finland where they did give neonates 2,000 units of vitamin D a day during their first year of life and followed them for 31 years, and it reduced their risk of getting type 1 diabetes by 88%.
Wow. 2,000 IU per day in a neonate.
In neonates, yeah. So then in typical fashion, the so-called experts came in and said, wait a second, too toxic. So then they cut it down to 1,000. And then they said, no, you only could be on 400. So then they started 400. So in the 90s, neonates in Finland now get about 400 units of vitamin D. And the incidence of type 1 diabetes is like on a rocket. It's on an exponential curve upward. And maybe there are other things going on as well, but it is interesting that as they cut down on the vitamin D intake in infants, the incidence of type 1 diabetes markedly increased.
And I think this is a perfect example of the action of vitamin D in immune programming as well.
No question about it. I mean, we know that immune cells have a vitamin D receptor, and we did a study recently in healthy adults where we gave them 2,000 units of vitamin D for just 3 months in the wintertime. And what we did was we collected their immune cells and looked at gene expression analysis for over 22,500 genes.
Yeah.
And what we found was that 791 genes were either turned on or turned off that controlled about 80 different metabolic processes just by improving your vitamin D status by taking 2,000 units of vitamin D a day during the wintertime.
So I think we can pretty safely say that if we gave 2,000 IU to pregnant women per day during pregnancy, that them plus other sources like their multivitamin and some responsible sun exposure and milk, that they can then get enough vitamin D to help with normal immune programming, normal bone metabolism, and protection from autoimmune diseases in their infants. Is that correct?
It's probably. I mean, like I said, we can't say that unequivocally, but all the data is suggesting that that is the case.
Yeah.
And then we recently wrote a review on epigenetics. And epigenetics, of course, is a very important controlling factor for how your genes are reacting to your environment. And we find that vitamin D is playing a critical role in that process, both in utero and throughout life.
Can I just ask you about two studies done by the Assemi author? And this was looking at vitamin D effects on glucose metabolism, lipid concentrations, and inflammation in gestational diabetes. And there's two studies, one in 2013 September, one in 2013 December. And they showed slightly different effects. Can you comment on those, about their relevance?
Sure. I mean, what they did was they were looking at some of the cytokines that we believe are important for reducing immune response, and suggested that by improving the vitamin D status, that there was improvement in these cytokines, which are playing a role in increasing risk for type 1 diabetes. So even though you're right that the two studies were a little bit different, it still came to basically the same conclusion.
Yes, yeah.
That improving vitamin D status improved the immune system in the right direction that would potentially reduce your risk for type 1 diabetes.
Mm-hmm. And beneficial effects on their glycemic control and the LDL cholesterol concentrations, which was very interesting in gestational diabetes.
Exactly.
Yeah.
And there are other studies out there that have shown that mechanistically that the active form of vitamin D, for example, decreases foam cell development, which of course is the precursor for atherosclerotic plaque.
Yeah.
And also seen in diabetes.
Yeah. So, what dose of vitamin D should we be concerned about during pregnancy? Like, you know, what contraindications? You mentioned sarcoidosis, which is an obvious one, the granulomatous diseases. What about pregnant ladies with arrhythmias or something like that?
So, yeah, or if they have kidney stones, right? Or and so it turns out that most of the studies have shown that if you have this amount of vitamin D intake, it will have no negative impact on cardiovascular health, does not increase risk for kidney stones. It really has no adverse side effects. In my opinion, there is no downside to increasing your vitamin D intake during pregnancy.
And I think this is an example of the safety mechanisms, the elegant safety mechanisms that our body has in controlling vitamin D when it's taken orally or certainly from sun exposure, that it actually, the higher the blood levels of vitamin D, the more breakdown happens.
Correct. And that's exactly right, is that what happens is that as you produce the active form of vitamin D, it instantly tells the cell that it's in to destroy it because it's so potent and so powerful. And as a result, you're right that if you have too much vitamin D on board, if you make too much active vitamin D, then this mechanism, the 24-hydroxylase, kicks in. And as a result, can control the vitamin D activity in a healthy way. There is one paper that came out in the New England Journal of Medicine that you probably saw about now a couple of years ago, where they showed that in extremely rare circumstances, severe hypercalcemia of infancy, the cause is mutation of the 24-hydroxylase. So they have essentially no 24-hydroxylase activity. And if they don't, then even a small amount of vitamin D can be toxic to those infants.
And you can't pick this. You've just got to wait and see if there's any adverse effects, and then test.
Correct.
Yeah.
I mean, what's recommended is, during pregnancy, is that you don't really need to measure the 25-hydroxy vitamin D levels, like I said, but rather you want to measure the serum calcium. And only if the serum calcium is going up, then you have to begin to be concerned that this could be a vitamin D problem.
Gotcha.
But almost never is this seen. And like I said, the Holick study gives us a level of comfort. 4,000 units a day was perfectly safe, not even a change in the 24-hour urine calcium.
It was a really interesting one. Sorry, Michael. That just came up yesterday when I gave a talk to college students, and I was like, "What? You've got a hydroxylase?"
And try to get to the bottom of it.
Yeah. Because I said, "Well, what? You've got a hydroxylase deficiency or a vitamin D receptor polymorphism? What's happening here?" And she just said, "I don't know. I've just got really low levels of vitamin D and brittle bones, and no amount of vitamin D will increase it." And I went, "Okay." I thought I'd ask you.
It's a possibility. We did report, and there's only 2 reports in the literature that on extremely rare is a 25-hydroxylase deficiency, and we reported a kid with rickets that had very low 25-hydroxy vitamin D. No matter how much vitamin D we gave, that child couldn't raise the blood level to any significant degree.
Right.
So that's a possibility. But usually these are malabsorption issues.
Right. Okay. Yeah. Okay. Now, Danny wanted me to ask. Sorry, Marcus. Sorry to interrupt. What did I scribble down there? I think we might have covered it from yesterday. It was preeclampsia and gestational diabetes. Yeah. So, Michael, are you comfortable answering that? If like practice points, if for pre-existing gestational diabetes and preeclampsia?
Say it again.
Would you be comfortable stating any practice points of care, not just vitamin D, with regards to gestational diabetes and preeclampsia? Because I know that like calcium's been used.
Yeah, I'm happy to. Yeah, and calcium. But I mean, basically, what we say is that there's no reason not to do this. There's a lot of information to suggest that it may be beneficial, but whether or not, for sure that it does work, we don't know, because we don't have randomized controlled trials that have demonstrated its efficacy.
Gotcha. So, Marcus, are we recording this? Whoops. You'll let it? Okay, great. So, I wonder how we can just frame that up.
I'll be happy to say it again. So my recommendation has been to pregnant women who are concerned about type 1 diabetes as well as preeclampsia, is that it's very reasonable to be taking a 2,000-unit supplement of vitamin D, a prenatal vitamin containing vitamin D, and other sources of vitamin D, so they're getting about 3,000 to 4,000 units a day.
Yeah.
It definitely has the possibility of reducing risk for preeclampsia and type 1 diabetes, but we don't know that for sure because we don't have randomized controlled trials that have demonstrated efficacy. But there's a lot of publications associating vitamin D deficiency with increased risk for preeclampsia as well as type 1 diabetes.
So, Michael, thank you once again for taking us through the relevant issues with regards to vitamin D dosing in pregnancy, in gestational diabetes, and indeed in those women suffering from preeclampsia, and the effects that healthy vitamin D supplementation and indeed exposure from sunlight can have on long-term health outcomes in kids. So thank you so much for taking us through that.
It was my pleasure. Have a delightful day.
Thanks, Michael. Bye-bye. I'm Andrew Whitfield Cook. This is FX Radio.